Dooley noted, 6/5, 2015. Hi, I'm Dr. Kathy Dooley. I'm here at Catalyst Sport with the amazing Dr. Kento Kamiyama. We find that when we are tutoring students that they have a little bit of trouble with eye movement and understanding the difference between how the muscles move on the three axes, what that movement even is on the three axes, and also how to differentiate that from clinical testing. So let's just talk about that for a second. The x-axis, if you look at Kento here, is the movement that occurs for elevation and depression. So all movement is rotation around an axis, so the x-axis will permit elevation and depression. Y-axis will be abduction and adduction, which is movement away and toward midline. Abduction away, adduction towards. And, and then intorsion, extorsion occurs on the z-axis. Very good. So if we were to close up on this right here, and give Kento a break here, you can see a little chart that you can actually freeze frame for yourself and learn. On the x-axis, elevation and depression occur, and the way you can remember what muscles do what are that the recti muscles are straight forward. Rectus means straight, which means the superior do what you think they'll do. They'll elevate on the x-axis, and they'll depress on the x-axis. The obliques, however, obliques start with O, and so does the word opposite. Obliques do the opposite of what you might assume they would do on the x-axis. So superiors actually depress on the x-axis, while inferiors elevate on the x-axis. Good. On the y-axis, adduction and abduction. So this is the y-axis, so it occurs around the y. The recti muscles, for the most part, are going to be adductors, except for lateral rectus, your primary abductor. So superior, middle, and inferior rectus are actually going to move the eye towards the midline. The obliques, the second letter in oblique is B, the second letter in abduct is B. So the superior and inferior oblique plus the lateral rectus are actually going to move the eye away from midline into abduction. Obliques abduct. On the z-axis, this is intorsion and extorsion. This is the z-axis. So intorsion is also called medial rotation, extorsion called lateral rotation. We'll call them just intorsion and extorsion. Superiors actually intort, and I think of the word sin. Superiors intort. So superior rectus and superior oblique are actually going to move the eye towards the nose on the z-axis. The inferior muscles extort, and I always think that inferior people extort you, right? So inferior rectus, inferior oblique actually move the eye away from the nose on the z-axis. Cool. So let's go to clinical testing. After you've memorized what the muscles do in concentric contraction, we have to accommodate for the fact that these muscles have to respond to the length tension curve. So length tension curve is when a muscle is more powerful on one axis when they're stretched in another axis. This is why clinicians use the standard H for the cardinal signs of gaze. They're trying to eliminate certain muscles from their power perspective by utilizing the length tension curve. So let's cover what happens. A muscle is more powerful on the x-axis, which is this axis, if it's first stretched on the y-axis, which is this axis. So the superior oblique and inferior oblique are most powerful on the x-axis for elevation and depression when the eye is first adducted. This is because they're abductors. So if the eye is adducted, that means they're stretched in that plane, stretching them back like a rubber band, so that the most powerful muscle is then on the x-axis. The superior rectus and inferior rectus are the most powerful on the x-axis when the eye is first abducted, meaning that they actually are stretched when abducted, giving them great power potential when you elevate and depress if the eye is already in abduction. So your standard signs for H, if you're drawing the H, you start in the center for medial rectus on each side in the adducted eye position. Also, we know that that's going to shorten up the superior rectus and inferior rectus since they're adductors, as well as medial rectus. And as you move the eye into abduction on this left eye, what will happen is the lateral rectus pulls you laterally, therefore stretching the superior rectus and inferior rectus on that y-axis. So you end up pulling yourself up, and the superior rectus is the most powerful elevator when your eye is in abduction. So as you move the hand outwards, it's testing superior rectus. As you move the eye back down, lateral rectus, and then move the eye most inferiorly, inferior rectus. As you move towards more inline, now you're actually stretching out the inferior oblique and the superior oblique on that y-axis, because now we're moving the eye from abduction, which those two muscles do, now to adduction. So now the superior rectus and inferior rectus are already too busy adducting the eye, so your primary elevator is going to be inferior oblique. Your primary depressor is going to be superior oblique. So let's demonstrate that on Kento. You want to, Kento?
Yeah.
All right, have a seat here. And so let's zoom in on Kento. He's the man of the hour here. And Kento's going to follow my cardinal signs of gaze. So we're going to draw the standard H. So right now his medial rectus muscles are going to be your primary muscles adducting the eye, but we're also being helped out in a short position by superior rectus and inferior rectus. So if I were to move Kento over to this side, his left lateral rectus and his right medial rectus are being pulled into their short positions. As I move my hand upwards, his left eye is in abduction, therefore I'm testing his left superior rectus because it's being stretched on the y-axis. If I move the eye downwards, I'm testing Kento's inferior rectus on the left. Now I'm going to go back up, Kento. You doing all right?
Mm-hmm.
This can make people a little bit dizzy. You can see he has an asymmetrical eye movement, right? This left side lateral rectus is a little bit lazy. It doesn't want to come into abduction, right? His medial rectus is really strong on the right. So on his right eye, watch his right eye as I move upwards. See how his right eye is in an adducted position? We're now testing the inferior oblique on the right eye. And as I move down, this is his superior oblique on the right eye. So depending on where, if the eye's in an adducted or abducted position, you're testing different muscles. That's why clinicians use the standard H. They go up and down, they go back to center, and then they move to the opposite side. This is the most efficient way to test these 6 muscles. Very good, Kento. So Kento's got it. You okay?
No, but
Can make you a little bit dizzy. So we know Kento has got a little bit of trouble abducting this left eye, but it's also in both planes too, right? So there might be a little bit of weakness in abduction, and we have a little bit of incongruency with superior rectus and inferior rectus. So since the muscles of the extraocular muscles have 3 different innervations, it's extremely clinically important to be able to break them down using the standard size of gaze. It's very confusing, right? Link tension curve, right? We learned the superior oblique puts the eye down and out, right? Because it abducts, depresses the eye, and in towards it. So it moves the eye like this. But the patient doesn't complain of moving the eye down and out, right? They have trouble looking down when the eye is adducted or in. So they have trouble looking, they get diplopia, double vision, when they go down the stairs or reading the paper. Right? So you have to think about not just what things do when they're short, but what things do when they're long on one axis versus the other. So the clinical testing can be very confusing. If this is troublesome for you, spend some time. Learn first what they do when they're short, and then understand the link tension curve, and learn what things do when they're long on one axis versus the other. I think this will really help you understand power. And if you really struggle, use a rubber band. Things are going to have their most power ability when they're first stretched. And then you let it loose. If you want to fly a rubber band across the room, you definitely pull it back first. So that's why this clinical testing is very suitable. I hope this was helpful. Kento, you're amazing. Thank you so much.
that was very helpful.
Yeah, and we have some work to do on Kento's eye movement. Eye movement really plays a part in full body movement, especially on the X and Y axis. Because if Kento can't access abduction of the left eye, he might have trouble with abduction of the left hip. So, and even into the foot, right?
Oh, absolutely.
Yeah. So the eye movement is wired by the cerebellum, mostly at the pons, right? A little bit of midbrain too, right? But midbrain and pons, and those are the same embryonic centers as the cerebellum, your motor control center. So people love to compensate with eye movement, or a lack in motor control shows up in the eye. I hope this was helpful. If you ever want us to analyze your eye movement, come to Catalyst Sport. We'd love to help you with this, and you should know always where your eyes are in space and get them analyzed. Duly noted. Thank you, Kento.
Thank you, Kathy.